Well, thank you so very much. I thank Mike Bettel for this invitation and the organizing committee. I could not be more honored to be here with you today. I've got the overarching task, and I'm going to try and do this in under 10 minutes, allowing for my colleague, Dr. Steve Harrison, to really have a little bit more time to talk about pharmacotherapies. And in so doing, I am not going to be doing a deep dive into a lot of data, but really giving a very high arch overview of where we stand with current treatment. It cannot be emphasized enough that the backbone of treatment for what now is metabolic associated steatotic liver disease, I'll use these terms interchangeably, is the foundation across the entire spectrum, from benign steatosis or simple steatosis all the way to cirrhosis, of lifestyle modification. It is a must, no questions asked. And on top of that, we will layer on systematic and stepwise approaches to addressing pharmacotherapies, which Dr. Harrison will readily talk about. And of course, other considerations which you may entertain in your practice, such as even bariatric surgery. For the scope of this talk, we're going to be talking about pharmacotherapies. This is for lifestyle modification. So the overview of lifestyle modification is really the more weight you lose, the more effective you can, or our patients can be, in resolving steatosis, steatohepatitis, and even improving hepatic fibrosis. And as you could see here, as the disease progresses, we try and be a little bit more cautious about protein restriction and intensive calorie restriction in those patients with cirrhosis, but effective weight loss is therapeutic. We strive towards a Mediterranean-style diet, encourage regular meal plan eating, sometimes even more frequent smaller meals in patients with cirrhosis, avoiding snacking, and as Dr. Ranella alluded to, of complete minimization, if not absolute avoidance, of alcohol in patients with advanced hepatic fibrosis and cirrhosis, and what I would consider a carbohydrate restricted diet that is as much devoid as possible of complex sugars such as high fructose corn syrup and processed and packaged foods, which are enriched in hydrogenated fats. And on the backbone of those dietary recommendations, talking about increasing physical activity, striving towards 10,000 steps per day, and really adapting any type of physical activities that our patients can otherwise accomplish, because the data would suggest it doesn't really matter what they do, whether it's aerobic exercise or resistance exercise, if they can do it and sustain it. That both these approaches lead to an improvement in hepatic steatosis, granted via different mechanisms. However, both are comparably capable of improving hepatic steatosis. Now, there is an intensity grade here for patients that can exercise more moderately, more frequently, more vigorously. It doesn't really matter, but this is one study that suggested that more moderate to intensive exercise has more magnitude in improving intrahepatic triglyceride storage. So what our patients can do, and in the intensity and frequency they can do it, matters. But the data also suggests that routine physical activity systematically across multiple different studies. This is a meta-analysis of 28 randomized trials of exercise in patients with metabolic or non-alcoholic fatty liver disease, systematic reductions in intrahepatic triglycerides that is concordant to reduction of liver aminotransferases, and another meta-analysis that shows that if lifestyle modification is associated with weight loss, that weight loss systematically improves liver aminotransferases as a marker of necroinflammation, as well as intrahepatic triglyceride stores. The challenge for us, and why emerging therapies are so important, is the reality is under 10% of patients after a 1-year intervention can actually achieve weight loss and sustain it. So while we can achieve resolution of steatohepatitis in those that achieved more than 10% weight loss, and we can even get fibrosis regression. The reality of that is the yo-yo effect, the inability to retain long-term weight loss renders our need to explore other avenues on this backbone. So there are direct and indirect effects of exercise, from improving fatty acid uptake and lipogenesis, reducing intrahepatic fat stores, helping with resolution of inflammation and lipotoxicity. And so exercise ultimately slows down progression of steatohepatitis and fibrosis. The unfortunate reality is we really do not have long-term randomized placebo-controlled interventional studies in this therapeutic landscape. But in those patients with advanced hepatic fibrosis, there is data that routine physical activity and exercise improves sarcopenia, and it can decrease not only the risk for fibrosis progression, but even decrease the risk for liver cancer. So imperative that we encourage this in whatever way possible. And on the backbone of diet, as you've already heard from speakers before me, limiting excess calories, the excess carbohydrates and saturated fats, there is a dose-dependent worsening of hepatic injury, both necroinflammation and fibrosis, with excess fructose consumption, restricting and completely limiting alcohol consumption, particularly in those with significant hepatic fibrosis or cirrhosis, and encouraging coffee consumption is good. So striving towards, as you can see here, almost a farm-to-table diet enriched with antioxidants, enriched with omega-3 fatty acids, enriched with choline and coffee, while limiting complex carbohydrates, red meat, refined sugars, and hydrogenated fats. Now, the techniques to support our patients, we really need more research in this area. There are those that advocate for SMART goals, be very specific, measuring the outcomes, making them achievable and relevant to the patient, and allowing for them to assess these outcomes in a timely manner. We need action plans, where, when, and how they can achieve this, and scalability so that they can measure and be comfortable and confident with the goals that they're achieving. And so self-monitoring devices have been utilized now in clinical trials, whether it's with scales, whether it's pedometers, whether it's daily diet and apps to measure calories. Those are things that we can implement in our practice. So I was asked to comment very briefly on accessibility and challenges. And it's important to keep in mind that there are strong undercurrents of social determinants of health. They're going to define whether our patients are successful or not successful. Time. It takes time to exercise. It takes money and cost to eat healthy. It's cheaper to buy supersized French fries than it is sometimes an apple or an orange. And the element of motivation, patients feeling that if they've been obese for a lifetime, they just can't do this. And we have to turn that table around to that they can't. Working within the constraints of their physical barriers, patients with obesity and metabolic syndrome have comorbidities that may restrict their ability to be physically mobile. And the element of aging also be a restricting variable. As patients become more fibrotic with age, they also become more limited in their ability to be mobile. There are issues that need to be addressed on a societal standpoint. Safe neighborhoods, for example. Can people go out for a walk? Can they go out and play, kids? And the iPad, iPhone, electronic era where we live in, where as a society, we are more sedentary. Not to mention issues related to food deserts that we see in some of our communities, where the closest grocery store for fresh food may be miles away. So a lot of research is needed in this space to ascertain social determinants of health on both a local level, but we also have accessibility challenges more on a societal level, where we have to increase awareness, address media and social networks to heighten public awareness, and work our way up this ladder that we are getting effective health professionals being motivated, having the liberties to take the time to address complex metabolic diseases in their practice, but also having public policy behind us that encourages, endorses, emphasizes, and mandates dietary changes, and addressing even issues of education, both with diet, exercise, and making societal adjustments. So the take home, lifestyle modification is foundational. Lifestyle treatment resulting in weight loss is imperative for reversing steatosis, liver injury, and fibrosis. Not one size fits all. We have to make the allowances for a menu of options and opportunities in a tailored approach for our patients. That benefits of lifestyle modification is linked to intensity and adherence, not necessarily the type of exercise itself. Combining dietary changes with exercise that endorses weight loss may have greater cardiometabolic benefit. And lastly, to identify and look at this from a holistic vantage point, that we can, by doing this, also achieve cardiometabolic benefits and improvements in type 2 diabetes. But we certainly need to break down the barriers, the challenges, both on a local level and a societal level to innovate change. Thank you.